So they connect academia, they connect business, they connect the providers of health and social care, and they connect citizens, and increasingly citizens are being a political word, people who live within the community. Connect them together to design and pull better solutions through into the marketplace and into the offerings that clinicians make to the public. So, in its purest form, we would like to start with need. So we would like to understand what is the need that the public experience, and what is the need that providers of care, doctors, nurses, therapists, social workers have, so that we can help link industry and academia through to those needs to come up with creative solutions that can be evaluated. And if they serve their purpose, then spread into across the country and beyond. That's the ideal way in which we work. However, very often where we are is taking discovery, which is somewhere around the matchmaking, independent of the need, and then trying to retrofit the discovery back into the need that people have, which is, it can work very well, but it's not the purest way in which we work. So my organisation is about a £3 million per year organisation, quite small, 40 people in my particular team. And all of our money comes either from NHS income, or it comes from the Department of Science, Innovation and Technology. So part of our commission is to work with these organisations who are gateways for innovation into practice, and also often funding, and often the gateways of research studies. These are the people who come together to commission our services. We are a non-profit organisation. And then in addition to this list, we directly get funding to support industry, and much of the industry that we support is small industry and start-up industry. So although we are connected as 15, and there are many programs we work on as 15 so that we cover the whole geography of England, the way in which we work is very local. So all of our connections are into those 9 universities within Kent, Surrey and Sussex. They're into the hospitals, they're into the local government that serves that 5 million population. So we create those networks and we nurture those networks. We build communities of public voice, and that's what we bring together with industry and with academics to help design better solutions. As a network, we also measure our impact, and I put this slide in, not to go through each point, but so that you can see. So we create jobs. By allowing companies and supporting companies to grow, those companies can create more jobs, and that is of value to the economy within England, so it's part of our purpose. We safeguard jobs. We also monitor how many people innovation is reaching, and sometimes that's quite difficult, and as a network we tend to say that people benefit from an innovation without necessarily knowing that that's true. And really what we're saying is we know the innovation is reaching care pathways, but we have to become more sophisticated to understand who are the people who are benefiting from that innovation and who are the people who are not benefiting. It's important to realise some of the limitations at the moment. But as you may know, there's a big call at the moment in the UK, particularly in England, for secure data environments. I am supporting the creation of a secure data environment along the south coast of England, which is about 11 million people. And we're working both with academics, also with the public, but also with industry, to see how that data can be used much more creatively to support measurement of benefit, but also so that industry can work and understand which of their innovations are working best and why. So, AHSNs don't exist in a vacuum. We occupy the middle territory, so we are a bridge between academic research and discovery and the benefit and delivery of care that hospitals, community services, mental health services, local government, public health are all commissioned to supply. So we sit between and we support discovery, although we ourselves are generally not researchers, and we build relationships with the people who are supplying care so that the discovery is visible to them, the evidence for the effectiveness of the discovery is visible to them, and they can own some of that research and pull the findings through into care. So we believe that pulling is far more efficient than trying to push solutions into a community that are not cited on the work that has been done. Oh, I'm sorry, this is somebody's slide that I borrowed. I'll just skip through. So there is a science and also an art to how we implement innovation. So discovery is not enough. It is not enough to say, here we have this fantastic thing. Usually, there needs to be a science around the implementation. So even with vaccines in COVID, where there was a huge desire to pull those vaccines through into communities, people were demanding vaccines in England. I'm sure there were in your communities as well. It's not enough. And there are always, for everyone who is demanding that innovation, there are people who don't trust it, there are people who don't want to use it, and there are clinicians who don't want to take every single new thing into their practice. They want to stay with what they've grown up with and what they know. So there is a science around bringing discovery and innovation through into care pathways. And some of this science addresses some of the reasons why, left to its own devices, innovation doesn't spread as quickly as we would hope it would. So AHSN's work with industry in a particular way, through our commission, through what we are asked to do by the Government Department for Science, Innovation and Technology, any company who comes to us, we will help. So that is a free service. We will meet with them, we will listen to what they are offering, we will think about how that offer has a value and discuss the value proposition for the communities that we serve. So that's a free service. Over and above that, there's more and more specialist support that we and other members of the network of AHSNs can give to companies. So we don't all possess every bit of experience. There are some things that we are very good at in Sussex. There are some things that we would refer to another academic health science network, either because of their connections or because of their expertise. Our journey as an AHSN is sort of shown on this slide. So 3 or 4 or 5 years ago, we were doing most of our work by far was those first meetings with companies. We were having a lot of first meetings. We were talking about the value of their proposition and their innovation. And we were not then forming a relationship with them. We gave them advice, they took the advice, and they went away and did whatever they did. Now, we are growing the number of companies who we work with and go on a journey with, and it's not a single touch, it's a partnership. And that's a partnership when we apply for research money together, or it's a partnership in how we support them to meet and influence the purchasers of care and the commissioners of care, and also the clinicians who are offering care. So we are now able to work far more as a relationship with companies than we were to begin with. And that's reflected in some of the returns, which these are not in billions, these are a smaller scale, but we are supporting £1 million turnovers and more than that, and delivering that sort of uplift to the local biotech and health economy through the work we're doing with those companies. All AHSNs return their figures, and the way in which it's calculated centrally by NHS England, I couldn't go into it. I don't understand the methodology. There are so many different economic models. So but this is the accepted one that all AHSMs work to. So I said on the previous slide that we sit between discovery and the delivery of care. And one of the big funders for discovery in the UK is the National Institute of Health Research. One of the ways in which they fund discovery is discreetly through applied research collaborations. And there are 15 academic health science networks, there are 15 applied research collaborations. We each serve the same geographies. So I work with Kent, Surrey and Sussex Applied Research Collaboration. And all of the ARCs have discrete themes. So because we serve a population that is quite deprived, that is coastal, and although we have 3 medical schools, we don't have an Oxford, we don't have a Cambridge, we don't have an Imperial, which are in other parts of the country. The areas in which we support research are around primary and community care. So this is outside the hospital, community care, care in people's homes, care for the generalist primary care physician. We support social care research, and we support social care research for the country, not just for Kent, Surrey and Sussex. So we lead on that. We have policy research units for the government within Kent, and we have quite a good standing in terms of research in social care. And then in addition, we do quite a lot of research in mental health, and in particular we focus on children and young people's mental health and mental health in the elderly. So less so working age mental health, but the 2 other age groups. So this is our area where we support discovery. And because we work in the way that I've described, as well as supporting the academics to be interacting with frontline staff and the public, so that the questions that they are trying to discover answers to are relevant to the care, to the provision of care. As well as doing that, we also very much advertise that to the providers of health in Kent, Surrey and Sussex. So there are 3 big providers of health within Kent, Surrey and Sussex, and some of their senior staff sit on a panel to support what are the questions that research answers. So in this way we try to make the research a capacity for the people who are commissioning healthcare to influence, so that the projects that are undertaken are relevant to the needs of the people who are living in Kent, Surrey and Sussex. So this is not discovery divorced from local need. It is discovery embedded in what people need to have answers for. And that's how this part of the funding works. NIHR are big funders. They have a lot of programs, they have a lot of calls that are themed around various things. They support a lot of research infrastructure. When it was known that I was coming to talk to you today, NIHR were very helpful in providing me with some slides, and they want you to know that they are there to support trials and access to funding within the UK for Korean companies. And I understand that there will be a memorandum of understanding signed in a couple of months' time between the UK and South Korea. And I'm sure that NIHR will be a part of the offering that I hope you would feel attracted to, even though it's not who I work for, it's a partnership organisation. Within that slide I showed you earlier with a number of partners. So NIHR are very well thought of internally, and they command a very good network themselves. So they are good people to do business with for clinical trials, because they can reach clinicians of all sorts. They've got a national reach, and their turnaround time for approving studies is becoming very, very competitive now, at around about 2 months, 2.5 months. So attractive. So I've talked quite a bit about the generality of what we try to do. And I've said to you very briefly that innovation reaches some people more easily So within the UK and really across all societies that I am aware of, there is a divide of people who do very well out of health and social care and people who don't do so well, who that evidence-based offering isn't reaching. And we're thinking a lot about that now in Kent, Southern Sussex, and we're thinking a lot about it as a country. And so at the moment, the NHS is thinking for 5 major areas of illness, ill health. This is where the greatest inequality sits between the people who have relatively long life expectancy, relatively long lives unaffected by illness, and at the other end of the spectrum, people who live less long and live more of their lives with illness. And the big areas are cardiovascular, respiratory illness, mental health, cancer, and maternity. So in those areas, there's now a big programme thinking about how can the benefits of good healthcare, evidence-based healthcare, be brought into those people who are not benefiting as much from them. How does the offer need to change? Is it a different offering, or is it the same offering made in a different way so that communities can trust it and access it? And this is where a lot of my thought is going at the moment, of how we do, when we're doing innovation, we're not leaving people behind. That's my last slide. This email address is for the network they have just sent, and my contact details are in the materials. So please do get in touch with us if anything we've said is appealing or useful to you. Thank you.
Thank you very much, Mr. President. With this detailed presentation, we come up with a solution for